Hi guys, my name is Lydia Khan. The drug I'll be discussing today is psilocybin, or more commonly known as magic mushrooms. Psilocybin is a popular psychedelic drug that affects the serotonin distribution in the brain, causing hallucinogenic effects and euphoric highs known as trips. These trips are commonly associated with feelings of nausea, dizziness, vomiting, and high anxiety. However, there are no withdrawal symptoms after the drug has left the body. Lack of withdrawal symptoms and the low toxicity levels of the drug make psilocybin a very unlikely drug to cause addiction. Psilocybin had a boom of interest in the 1960s and 70s, leading to misuse of the drug both recreationally and scientifically. With an overload of negative publicity on the drug, psilocybin was declared Schedule I substance by the Food and Drug Administration in the 1970s. Psilocybin is not new to society. It has been used for centuries. The Aztecs used it ceremonially and to enhance spirituality. There were findings of psilocybin use in Spain during the 1500s. Later in the 1960s, a famous scientist, Albert Hofmann, repopularized psychedelics when he published the Journal of Psychedelic Drugs, sparking an interest in the drug both recreationally and experimentally. At the time, there was not many regulations for how to go about research with psilocybin, leading to controversy on top of controversy of unethical studies being performed. The government compared LSD to psilocybin to determine if the psychedelic would make for better interrogation methods. They administered the drug without consent of the participants. Interestingly, they found that LSD was preferred because it had a greater sedative effect. Eventually, all the negative attention from the public eye on psychedelics led to its classification of Schedule I drug. All the funding for research was pulled from the government. Conducting studies with psilocybin became severely limited and incredibly difficult to conduct. Psilocybin has an attached phosphate group on carbon 4 that makes psilocybin difficult for the body to metabolize. Dephosphorylation occurs in the stomach due to its high acidity. It can also occur in the kidneys and blood. A hydroxyl group takes the place of this phosphate on carbon 4 to form psilocin. Psilocin is a more lipid-soluble form that allows the drug to be absorbed into the intestines and from there attach to plasma in the blood and pass the blood-brain barrier. Psilocybin affects the distribution of serotonin in the brain. It is an agonist for receptor 5-HT2A that disrupts firing of serotonin to the dorsal Ralph nuclei, causing a domino effect in the rest of the brain. The areas that are largely affected are the prefrontal cortex, thalamus, and cortex. The prefrontal cortex is responsible for abstract thinking, for mood, and for perception, and it has been shown to be affected by depression, and psilocybin causes reports of users experiencing changes to mood, perception of life and self, acceptance of spirituality, and out-of-the-box thinking. Hallucinations that are common with trips are caused by disruption of sensory input to the cortex. Along with these areas of the brain being affected, there's also increased levels of stress hormone cortisol that increases control of emotional processing while absolving negative emotions and thinking. This image shown here is taken from the study looking at connections in the brain. On the left is from a patient giving a placebo, while the image on the right is from a patient consuming magic mushrooms. As you can see, there's a drastic increase of connectivity for the patient with psilocybin. Psilocybin produces a wide range of effects within the first 12 hours of consumption, from feelings of euphoria, excitement, and joy to anxiety, nausea, and paranoia. A large reason for interest in the drug is the hallucinations that are commonly caused by the psychedelic. The hallucinations can range from brightness of color, distortion of faces, moving surfaces in the wind, wave-like motions. Each experience is unique to the taker. The hallucinations can be a root cause to both good and bad trips. The cortex being largely affected by the drug encompasses the part of the brain that perceives time. The combination of impairment to time perception and intense changes to visual stimuli can lead to paranoia and anxiety, which do not bode well for a good trip. 35% of users reported to experiencing some form of anxiety while under the influence. Psilocybin is not typically an addictive drug. Tolerance levels in the body spike immediately after initial intake of psilocybin, except this spike is temporary and returns back to normal levels within days. Anyone with a desire to consume the drug again would not need a higher dosage the second time. Users also don't experience any intense withdrawal symptoms. The most common is a headache that usually goes away within hours. Many of the negative side effects occur while the substance is still in the body, not post-excretion like many drugs. There is a rare disorder that can develop called hallucinogen persisting perception disorder. It acts very similarly to PTSD, causing intense, unprompted flashbacks. These flashbacks take the person back to the hallucinations they experienced during the trip. This is a very uncommon development. In one study with 178 hallucinogenic users, only 22% reported experience HPPD, and a good majority of those people had been using several hallucinogens like LSD along with psilocybin. HPPD can last up to several years and has positive results to being treated with therapy. The first research study we'll be looking at was dealing with psilocybin treating depression. 20 patients who were diagnosed with TRD, a form of depression, were unresponsive to at least 2 different pharmacological treatments and were part of a 6-appointment study. They were given a screening session, followed by a preparation session, and then given a low dose of 10 milligrams of psilocybin. And then a week later, they were given a high dose of 25 milligrams of psilocybin. This was followed up 1 day later, and then again 1 week later. There's also a 6-month follow-up, either in person or online. The demographic included a mix of men and women, several different ethnicities, ages ranging from 30 to 64 years of age. Each patient was introduced to 2 experienced clinicians during the screening session that stayed with them during their trips. 6 participants were depression-free 6 months later. 7 had a reduction of 50% of symptoms, and 2 reported not experiencing any effects of the drug, both post-use and during consumption of psilocybin. They had no symptoms. The process of change in depressive states post-psilocybin treatment was accounted for in 3 different variations in this study. Depression was described as a state of disconnection either from self, those around them, or the world. Psilocybin was shown to bridge these gaps and was profoundly helpful in these cases. The second one, patients experience depression as avoiding pain in the form of thoughts, memories, and feelings. Psilocybin allowed for acceptance, confrontation, and embracement of this pain. The last step compared treatments of psilocybin. Talking therapy and medication work to accept pain and reconnect them, but psilocybin effectively seeked out this change. Nearly all those who showed positive responses to the clinical treatment explained how depression felt like a prison for their mind, and the treatment was a release. They were no longer trapped under the weight of their own mind, and was a form of reconnection with their consciousness. The second study we'll be looking at was understanding the use of microdosing in a form of treating depression. This study was a cumulative analysis of data and not in a clinical setting. A program was developed to analyze input from respondents to accumulate their own findings from their own independent microdosing endeavors. 50 of the 278 participants microdosed using only psilocybin. This research was conducted to understand the benefits compared to the challenges of microdosing. All subjects experienced some form of depression. The biggest findings were 26.6% experienced improved mood, 12.9% felt improved creativity, 14.8% reported improved focus. The biggest challenges reported were 29.5% were challenged by the illegality of the circumstances, and 18% faced physiological discomfort, and 6.7% dealt with increased anxiety. What seems to be an imperative piece to every study I have reviewed is the inclusion of talking therapy and guidance of experienced psychologists for positive results. One gray area I have discovered has been the effect of psilocybin on treating anxiety. There have been several positive case studies of psilocybin effectively treating anxiety for patients who received an end-of-life diagnosis or a diagnosis of cancer. However, responses vary for other types of patients. Some of the studies show a decline of anxiety, while others shows elevated anxiety. What can be agreed upon is the high anxiety during psilocybin consumption due to the increased levels of stress hormone cortisol that is released. Substantial evidence is lacking, not due to failure done by current studies, but due to the overall lack of studies that have been conducted. More research needs to be done, more data needs to be collected, and more positive results need to be shown. The first study I presented should be replicated with a larger sample size, and the data should replicate some of the results. For microdosing, studies need to be clinical-based, not response-based. There's too much variability and inaccuracies that can be drawn. A setup similar to the first study could be replicated. Participants are screened, introduced to experienced professionals that can help guide them through the process. Then they should meet 3 to 4 times a week to administer the correct dosage and go through talking therapy sessions at least once a week. This process will be repeated for a minimum of 6 weeks. From there should be an evaluation of progress. Those who do not wish to continue or are not finding positive experiences from the study can opt to leave. Those who would like to continue would continue taking the dose or receive a new level of dosage if necessary and only need to meet once a week for a therapy session. I believe psilocybin has a great potential for treating mental illness such as depression. I don't quite think we are at the point of claiming that is definitely a good treatment option. More research and more positive results are needed. Psilocybin is still a Schedule I drug. This heavily contradicts many findings in this presentation. The classification of Schedule I deems psilocybin unsafe for use in both clinical, medical, and recreational settings. Before any real progress is made, this will have to be changed and either determined true or false. Thank you for listening.